Great. Just kicking it off. I appreciate you being able to come on and give a little introductory about your background as well as the course itself. And speaking of the course, why don't I just pull that up right here? And this is about you guys. It doesn't fit the screen all the way for some reason, but yeah.
Yeah, thanks for having me on. Love following your content. We were just kind of talking about you trying to get your licensure to start working. Have you gotten to pull a tooth out in the real world yet?
Hey, wait a minute. I'm getting a little interference with. It's like I didn't hear that. I'm sorry about that.
No worries. I was just saying I've been following along with your content. I know you've been having some delay with your licensure. Have you been able to pull a tooth in the real world yet?
Yeah. Finally, came in last Tuesday, and then I'll be starting actually next Tuesday. So 2 weeks to like matriculate all the onboarding process and stuff. But pretty excited, getting ready to go. And I started studying a little bit, reviewing here and there for the board exam. And I appreciate your insight on that, what to study, how to study for it. I'm looking forward to the course.
Yeah, it was great. Yenzer started that a couple years ago. I got to know him at the St. Louis course, which I think you guys might have done an episode on that. And I had a great experience. That was pretty much the only course I went to. And then I did group studying, but I'm in a group that's basically, we focus on maxillofacial surgery in private practice. We obviously do like oral surgery too, but we wanted to start something at first just to kind of help everyone within the group study for boards. But then it came to the point where we had fellows and then we had friends of fellows who want to do it. So we kind of morphed it into an official board course. Difference being there's no lectures. So it's all small groups, it's all mock cases, and it's all timed to 12 minutes just to give people a great start. There's obviously a lot of other good courses throughout the year, especially in January. Natural course is obviously very big. We wanted something early on just to give people a sense of what it's like to sit in a mock case that would be similar to boards. And we have a lot of surgeons within our group. I think now amongst, Virginia, North Carolina, South Carolina, it's 50 something. So the point is it gives us the ability to have a lot of one-on-one mock cases, and then you get a lot of reps in, and we're doing a lot of this stuff every day. So it just worked out nicely.
Oh, that's going to be huge too. And as we all know with studying for exams, I mean, this is a very different because it's oral, right? You're delivering the answers verbally, but as with every exam, it's still going to come down to repetitions. How much practice have you done over these months up until the boards with those cases, with those treatment plans? How did you manage the complication that arose in the middle of IV sedation, things like that? So, yeah, dude, do you know how many like faculty members for the course you're going to have there?
So last year, because we had to do it in small groups, I think we had somewhere between 30 and 40 participants, and we ended up having around 30 proctors. So the really cool thing is it's broken down into your standard sections, section 1, 2, 3, and each section you get a case from each discipline. But then we have stations for all of the individual things. So there's a station for advanced orthognathic. And for example, Brian Farrell, huge name in orthognathic surgery, he's taking you through all of the cases in a board style manner, 12 minutes, but then he goes through in depth of, if you get down the weeds of this is, some different things to consider. But one thing that we also did because we wanted to make this valuable for residents is a lot of residents don't ever get to run a treatment plan or a VSP. So I don't know what it was like in your program, but at UNC, we didn't really get to treatment plan orthognathic on our own until 5th, 6th year. And then by the time you do a VSP, sometimes you're not really sure how to start with engineers. So we actually have engineers live there with us. So that way you can kind of dictate what a VSP station or session would be like. And then whether you're in residency or private practice, you can run through that for orthognathic surgery. But then some people may have never done, say, one of KLS's IPS pre-prosthetic implants. So we have a station where you kind of learn to do that. We had last year, Dr. Maloro was doing the zygomatic implant station with Straumann there. So it's just kind of neat to have different people who are doing this all the time run you through a boards case, but then also throw in something that is a little bit more practical for you to be able to take back to your residency program or, use in private practice.
Yeah. It looks like there's a delay. So if you're seeing that too, that's fine. It all kind of cuts out and lines up, the program cuts that out and lines everything up as far as the audio goes later on. But wow, so you're getting way more in depth. You're not only going into like all the board topics, but also going more in depth. I mean, IPS, maybe zygomatic implants probably in the boards, but like the IPS cases that you guys are going over, that's extremely helpful for anyone in private practice, not just people preparing for the boards, it sounds like. You agree, right?
Yeah, we thought that, the first thing we wanted to do was make it a high repetition of doing mock cases, make it realistic. So that way you're getting 12 minutes, going through all the disciplines. But then we thought, well, the people who'd be going to these courses would either be senior level residents kind of getting ready for boards or people who've just graduated and kind of figuring out what they want to do in practice. And we thought this would be a nice way to fill in, depending on which program you went to or what your background and training is, it'll help fill in some of those gaps of things that, let's say maybe you didn't do a lot of trauma in your program, but now you're taking trauma call in private practice. Hey, here's how you can do treatment planning for custom mandible plates or for custom orbital floor plates. Still kind of focus on the board style questioning, but yeah, at the end they're giving you some extra insight on how to do some of these things that maybe you just didn't do before.
I love it. I love it. Hey, I'm excited for this course, man. I'm gonna put up a post about it and everything. And sweet. So as far as boards going, though, when would you recommend to start studying for this, or what would you say is the right time to start, or what would you say is too late to start? Does that, you know what I mean?
Yeah, I didn't really start studying until kind of right before the St. Louis course, which is, I think, traditionally in maybe early or mid-October. And I thought everything turned out fine. I would say, Yenzer did his kind of prep for oral boards a couple of weeks ago. And I think a lot of people are starting early and urged to kind of make it a little bit easier. I think the earlier you start, the more time you have to run through things. But I would say probably by fall, you should be at least getting into a rhythm of looking things up. And then towards the, late fall, early winter, really starting to practice all of the small group stuff with partners on Zoom or in person. I think as you're kind of hinting at, the difference in this is it's not just a materials thing. So you can be studying all you want in the background, but I think the earlier you do practice cases, the better it will be. And that's why we try to time our course to be a lot earlier to give people reps and all that stuff. I think last year, based on how many people we had, the average participant had 8 or 10 mock cases by the end of the weekend. So we're just trying to get everyone just to practice being comfortable with saying all sorts of different things, practice being comfortable with going through HPIs and exams and, evaluating radiographs. So I think that if you're listening to this now, obviously the earlier the better, but at the same time, if you start in the fall, I think that's adequate time to go through the material and really hone the things.
Okay, good. Because I know some people that I was chatting with in my group, because there's going to be 4 of us taking the oral boards exam, and we were just kind of going over timelines, and some people were kind of getting a little nervous, like, gotta start soon. But that, I'm sure, at least for listeners, when they hear you say that, they're going to feel a little bit more comfortable. Because I was like, I'm waiting to start working. If I'm not going to work, I might as well start studying, I guess, reviewing some of the topics. And then, and boy, what a surprise it is when you're like, God, I haven't looked at this in 4 years.
Well, it's also very different because when you are going to study, you have a rhythm of how you do things, even for simple things like wisdom teeth consults. But then when it comes to asking, what are the indications? What do you tell patients the risk of nerve damages or orthognathic, why do you do X, Y, and Z? It's just different when people are putting you on the spot and asking these things. So you can read it 100 times, but when someone asks you why out loud, it just puts you in a weird, different type of, discomfort. And I think that's what really people need to practice, saying things out loud and being comfortable, being uncomfortable. And that's the whole point of what we're trying to do, is really run through these cases. So by the end of the weekend, even if you weren't doing the case yourself, you've heard someone else do it. And now you kind of get a rhythm. Okay, if I get asked about how I do a trauma physical exam, I at least in the back of my head know where to start and kind of what major things to go through, which we think is probably the most helpful thing.
Yeah. That's such a great point. By the way, I love in the background the picture of the skull. I really like that. That's nice.
I was an art minor in college, so I did a lot of pen and ink, and it's a triple jaw surgery. I'll get you one.
No, wait. You drew. I'm sorry. There's really a lag. I've never had this before, but it's fine. We're doing just fine. But you drew that?
Yeah, it's a pen and ink. Before it be so ingenio, but yeah, I'll get you one.
Dude, that's really, you have talent, man. That's really talent. I love this. Dude, that's so sweet. So did you you said you do a lot of orthognathics in your practice, right? You're in South Carolina, your oral surgery group, Carolina Oral Group, Columbus, South Carolina, right?
Yeah, so Columbia is about an hour and a half south of Charlotte, and I'm part of Carolina Center for Oral and Facial Surgery, which was originally started by a group of surgeons, some of which were, Dan Spagnoli, Myron Tucker. And the whole thing was people were not really doing orthognathic surgery in private practice, kind of left to the academic centers. And one of the models that they kind of developed, and as we've kind of carried on, is that orthognathic surgery can be done in an outpatient center in clinic safely. And the nice thing about that is it allows for surgeons to practice, in a private practice setting. It allows for patients to avoid being in the hospital, and then it ends up saving insurance money because they don't have to pay for overnight admission. So basically, our offices, my office has a Triple HC accredited surgery center. So does a lot of the ones in Charlotte and Greenville and Rock Hill. And we can do outpatient orthognathic surgery, and that has morphed into also including TMJ surgery. We have surgeons who have done a high volume of total joint replacements in office. Patients go home same day. So we've been able to kind of create a system that allows for what you would traditionally think of being only done at the universities to be done in an outpatient. And then here in Columbia, there's a level 1 trauma center at University of South Carolina. So I take trauma call there and kind of operate at the hospital there. So it's a good mix as far as, your standard dental veolar practice, in addition to some of the things that people kind of have more fun with.
Oh, sweet, sweet. So you guys are really doing it, getting in an outpatient setting. Can I get an idea what your week to week looks like? What's your Monday through Friday? Do you work weekends? How often are you on trauma call at that trauma one you mentioned?
Yeah, so my schedule's a lot better now. I have a partner, Jenny Van Hook, who joined me from VCU, and then we've kind of partnered with some of the groups in the area for call. But my current schedule, I see consults and follow-ups Monday, and then Tuesday is kind of your traditional oral surgery day. So surgeries in the morning with sedation, and then some locals, and then consults in the afternoon. Wednesday is my OR day, so I have block time at the hospital first Wednesday of every month, and then every other Wednesdays in my surgery center in office. And that's usually anywhere between 3 to 5 orthognathic and TMJ surgeries. Thursday, I do sedations through the morning, and then I leave the afternoon for admin, and then Friday is just sedations. The good question about the call and how weekends work. When I started here, there was no oral surgeon at Lexington Medical Center, which is a level 3 trauma center here in town. And there wasn't anyone really doing facial trauma at the level 1. So I tell people, if you're moving to a practice and they don't do trauma call, you can go on the website of trauma centers and type in your state. It'll show you level 1, 2, 3 in the whole state. So I did that, and I basically just reached out to the ENT and plastic surgeons at the hospitals that had trauma centers here and told them, hey, I'm happy to take call. At the level 1 center, they were happy to kind of have an oral surgeon jump in, but they basically weren't, they already made the call schedule for the year. So I said, I'll just take, whatever days that you guys have something come up. And then from there, it was funny, the first referral I got from them was a pan face for a homeless person, but I think that's just kind of the hazing of it. And then once you get your feet wet and, show that you're willing to help out, I got into the regular pool of trauma call at that hospital and oral surgery call. The nice thing is at that hospital, there's a GPR, so they help out with a lot of the simple dental things and cardiac clearances and things like that. But at the level 3 trauma center, since they never had an oral surgeon, they said that they hadn't had anyone doing facial trauma since plates and screws were invented. So basically what I said was, I'll trade you taking call, because they weren't going to pay for it, for getting some block OR time, so I can do, some of my orthognathic and TMJ stuff that needs hospitalization. So for the first year, I basically took Q3, like every third day call, to get 2 block days a month. And then after that, I was like, okay, well, this is great, but I'd love to be compensated for call. So then what they said was, well, let's give you like a hospitalist oral surgeon salary. So they basically paid me a year's stipend. And then I was responsible for the first year, 300 days of call. Granted, there's hospitalists doing admits, there's trauma team doing admits for trauma. And then as that went well, it kind of morphed into, all right, we'll have a 365 call. You guys will get 4 block days a month. Because at that point, I could recruit a couple of other surgeons to take call with me. So in the first year, as things were building up, I was taking like Q2 call at the level 1 for oral surgery, facial trauma every week or so, and then 300 plus days at the level 3 trauma center. But as that's kind of gotten built and things have become established, now things for me personally is usually 1 to 2 weeks of call, a month of oral surgery, and then a few days of level 1 facial trauma call a month as well. But in the beginning, it was just trying to build things up. And for them, they didn't realize, how many patients needed extractions before radiation, how many people were having mandible fracture they were transferring out for trauma. So getting all that built up in the beginning was super busy. But I was building the practice here. They didn't have a Columbia location to start. So when I opened up the practice, I was still just trying to get referrals in the area to refer me, wisdom teeth and premolars. So it was good to meet people at the hospital and kind of get established as the oral surgeon in the medical community. And now I have a great relationship with plastic surgery, ENT, and a lot of these other people. So it's a good network for referrals as well. I know a lot of people don't want to do hospital stuff, but I think that a lot of the reason why my practice has grown from the last few years is meeting all the people in the hospital and early on. And now a ton of my patients are either physicians or nurses or, friends and family of them.
That sounds great. And it sounds like it's slowly getting better and you're kind of molding it into what you want to be. I mean, you're literally like the model oral surgeon of how it gets hard at first and then slowly gets better. You get privileges here. You work on getting over there. You get a good relationship with the other ENT and plastic surgery departments. This is going really well for you, man. This is exciting. Which is your favorite day of the week, though?
Well, I love
As far
Mondays.
as you're working all the hospitals, and then you have the sedations these couple days. Wednesdays are the OR day. I want to know like your personality. What's your favorite day?
I would say Wednesdays are my favorite in office. Reason being is, we all know what it's like being at the hospital. There can be a delay for no reason. There can be, pack you hold, all those types of things. And in the office, it's nice because you have control over, like I have the same anesthesia provider every day. I have the same assistants. I have the same pack you nurse, the same pre-op nurse, and we have a very good rhythm. And the nice thing is, while we're doing turnover, I can still do wisdom teeth consults. I can still see post-ops. I can come to my desk and do things. So the in-office OR days are just very productive. The only reason that I can do all of this, though, is the first year, as things were getting busy, I kind of acted like a fellow within our group. So, we have a lot of people doing a high volume of orthognathic and TMJ surgery here. And I basically would look at the schedule, and whenever there was a case that they needed help with, I would go and do assistant surgeon for Brian Farrell, Jim Howell, or Peter Franco, and just helping them out be their second surgeon for ortho cases. And then I had a good TMJ experience at UNC with Sean Matthews, but Dan Cook and John Nail really took me under their wing here and taught me like surgical arthroscopy and how they do total joints. And they've really helped me build my TMJ practice. So kind of I guess my point is first year or so was really just spending as much time with the senior surgeons, figuring out how they do things, not just, surgically, but how they manage a schedule. I learned the Monday consult day from Dan Cook, and he told me, hey, a lot of people like Monday off. If you take Monday as your consult day, you'll never come in after the weekend and not be able to do a consult. I think the stressful thing of why people have kind of the Sunday scaries is you don't know if, let's say it's your OR day, do we have the splints in? If it's wisdom teeth, do we have this cardiac clearance done? But if you come in Monday and it's all consults, even if you're coming in from out of town, it's nice to come in and know that it's going to be a more laid back day. And then utilizing Wednesday for OR day, Thursday is a half day for admin. But that way, when I take call, I usually take trauma call maybe Monday or Tuesday. And then that way I can just post cases for later in the week. I'm just trying to make this sustainable. And to do that, you can only operate so many times for manual fractures at 10 o'clock at night on a Thursday when you have two kids at home without your wife, threatening to leave you. So I'm trying to mold it into a way where I can still practice a lot of the full scope things, but just making it more practical from a day-to-day standpoint, schedule-wise.
Oh, yeah, dude, that was going to be my next question is how do you balance that between family life, doing the boards course? Earlier on, you were doing a lot of shadowing and stuff in the office, but you were still doing board studying. How you have young kids? Are they young? Like, you got to spend some time with them, right? How do you kind of balance this all? It's a lot of juggling pieces here.
Yeah, that's probably the hardest part. I have a 2-year-old and a 1-year-old now. So when I started practicing in 2021, I didn't have kids. And to travel to do these cases, Charlotte's an hour and a half drive, Greenville's an hour and 45 drive. So I was logging a lot of hours driving around, just trying to learn from them on some of the bigger cases. Honestly, the answer up front is my wife was very supportive. We moved to an area we didn't have any connections. We were trying to start this practice. She allowed for me to be going all these places, shadow surgery. And in the beginning, because I was taking so much call and I was really trying to build the practice, we had a joke that I had a block day on Saturday because I'd be doing all the traumas from Thursday, Friday on Saturday morning as a first start. But then in the beginning, it's just trying to, absorb as much as you can, do as much as you can with the end goal of making it sustainable. And I'm lucky that I have a partner, Jenny, who's very open to taking call, very open to assisting with bigger cases. And as we basically have every quarter try to evaluate, is this a schedule efficient? Is there anything that we can be doing better? I didn't always have a Thursday admin afternoon thing, but I kind of kept seeing how things are getting pushed into the week. I was obviously posting cases for after work Thursday or Friday. So kind of cutting that back helps a lot. But for studying, I would usually study before clinic would start just because by the end of the day, you're kind of exhausted now. And then my daughter was born in November of when I was studying for boards. I don't think she'll ever let me live this down. I had just joined a study group that Yenzer hooked me up with after the St. Louis course in October, which was mid-October. And then my daughter was born November 4th, and that was a Friday. And our boards group would meet every Sunday morning, but I had just joined their group. So I didn't want to be the person who didn't show up because you're supposed to bring your own cases. So that way you present a case, mock someone and they present a case. So there's 4 of us. So if I didn't have a case and it kind of puts them in odd numbers, Sunday morning when we go to log in, I was doing a mock boards from the hospital room and the OB was rounding and she came in and I was kind of in the middle of a thing. And my wife looked at me like, this is really crossing the line. But you just kind of, make different things work. And I guess keep evaluating, is this practical? Is this going to last long term? Because I think what I was doing the first year or two long term would not have fit anyone's lifestyle, especially if you have kids. But now that things have been kind of molded into something that's more practical, it's just all about being sustainable. You don't want to come out and do everything for a year or two and then, close out all the contracts you worked hard building up and all the relationships. I meet with the hospital administrators once a year to talk about, hey, do you need more block time? Is there equipment you need? Is there any policies we need to put in? In the beginning, because they never had an oral surgeon, the ER would call me about any dental pain, right? But we had to establish if there's no abscess, there's nothing that I'm going to be doing. So these are the things that be outpatient follow-up. These are the type of fractures that, need to be seen right away. But in the beginning, it's just tons of phone calls and establishing things. But I would say, as long as you're always trying to work towards something that's sustainable, we've been very lucky here where we're able to kind of, practice both sides and be involved with academics and still pick up kids from daycare and stuff.
Dude, that's nuts. I mean, the first year, driving an hour to this hospital, an hour and a half to that hospital, have your kid on a Friday, you have your boards class that you're taking in the hospital, and if your kid's born on Saturday morning, if this is a day, you're fitting this much in, you know what I mean? I love that. I really appreciate that. And I like how you're also giving hints of how to make your schedule more productive so that you can efficiently fit everything in. Because I think that's another question where it's like, initially we get out, we start practicing, you just finished residency. Now you think you have all this time, but the responsibilities of being a father, studying for boards, I'm trying to buy my house, so I'm going to have to figure out, the mortgage and that. And so it's kind of interesting to figure out how to navigate those things, learning from other oral surgeons that have done it ahead of you. So going forward then, how do you see your kind of career you're 4 years out, right? 4 to 5. Pretty soon. How do you see your career kind of molding into an even more productive, more efficient, maybe that means more time with the family. Maybe that means adding on another OR day. Maybe that means adding on another admin day. Do you see any changes in there in your future? I know it's early on, but I'm just curious what your thoughts are,
Yeah, no, it's a good point. And those are the things that I talk with my wife about, or people, in the practice, as far as what's their experience been of, there are partners in our group who have kids who are older, and how do they manage stuff. And just leaning into other people's experience has been very helpful. And I think for me personally, a lot of oral surgeons will talk about, do you take a Monday off? Do you take a Wednesday off, and kind of help reset? For me personally, I have kind of built my schedule so that way I'm usually done earlier in the day. So I try to be done seeing patients by 3 most days. So that way I can pick them up from daycare any day that I want to, or if I need to kind of add things like this or other types of meetings with dentists, I can do that today, but still be home earlier. So for me personally, I've kept the 5-day a week thing, but just ended earlier. And then I've made things more efficient where, in the beginning, you're scheduling wisdom teeth sedations for an hour. You don't want to rush or things like that. And then it becomes, every 30 minutes or every 45 minutes. And now we're at the point with between the nurses starting IVs, the assistants having worked with me for a while, and us having a good rhythm, we usually schedule wisdom teeth, every 20 minutes or so. So we do 3 an hour. So even though we're making the work day less and, not having to be here as long, I end up seeing the same amount of patients just because you become more efficient from a technical standpoint, but from an administrative standpoint. And then for my TMJ practice, I'm sure everyone knows that TMJ patients take a lot longer to go through their history, their exam, and usually they're just a lot more in their HPI as far as, what things they've tried and what's been difficult. So I got really lucky with this, but one of my recovery nurses, she was going to NP school, and she really liked working with the group, and we were very lucky to have her, Kylie. And after she finished NP school, she wanted to find a way to still stay in the group, and she has essentially been able to transition into a very heavy clinical role. So she, for all of my TMJ surgery consults, most of them are non-surgical. So she will go in kind of while I'm doing sedations, she has her own column of consults, and she'll go and get all the history, do, start off the exam and everything. And a lot of times when it's non-surgical, we have a great relationship with a physical therapist. So she'll start, whether it be muscle relaxer, she'll help them get us set up with a splint. She'll refer them to our physical therapist. And then I'll come in and meet them, make sure everything lines up based off of her exam and the history. And then if it seems like someone who needs surgery, she will get the MRI ordered and then kind of put them back on my schedule for a surgical consult. But for example, from an efficiency standpoint, that hour consult for a TMJ patient has now for me become closer to a 10 to 15 minute consult, just because a lot of that discussion is hard to really condense. So that's probably the major thing that we've had in the last few months. But things like that, I think as things grow, my TMJ practice when I started, I wasn't doing nearly as much, but now we're doing arthroplasties or total joint replacements almost every week because we're getting a referral network from basically Charleston, Greenville. It's kind of weird because Columbia is right in the middle of MUSC and Augusta. So there's no oral surgery program here. And we get to draw kind of patients from all over for TMJ surgery. But as that's grown a lot, it just wasn't really possible for me to see all these TMJ consults since most of them are non-surgical and kind of keep up with my dental alveolar practice. So that's probably the biggest thing that's morphed in the last few months. But moving forward, I think the main goal, and I guess I'm lucky because a lot of she's the same age as me, Jenny, my partner, same age as me. We all kind of have a similar goal of keeping things to a condensed clinic schedule, is just figuring out how to basically get the same thing that you would get done 8 to 5 into a 8 to 3.
Oh, that is genius. I don't know of any other practices or people, surgeons that I've talked to that has someone designated as like the TMJ triage person. That's so brilliant because then you could filter out everyone that doesn't need surgery, and that saves you time. It allows you to maximize your time elsewhere. Keep the new consults down to 15 minutes, and you already know it's likely going to be a surgical. That's that's so important to filter out the excess. And I know a lot of surgeons, like especially my co-residents, who are always talking about like, what do you think about doing THA in practice? You know how long it's going to take to see those patients, and then the follow-up, and then non-surgical management, and the time consuming, the reimbursement. Man, I'm glad we got into TMJ, because that is some really valuable insight right there.
Yeah, and the nice thing is, nurse practitioners, they can do Botox injections, they can do trigger point injections. They don't make mouth guards, but we have people who do that. And then from a financial standpoint, you're asking about reimbursements and stuff. The nice thing is she actually will assist me on surgeries, and there's a second surgeon reimbursement. So she collects a surgical fee for the cases that she's assisting with. And it's really helpful because she's in their surgery with me. So she knows, hey, he plicated this disc with the suture, or hey, he took this disc out and he did a fat graft. So she's just as familiar with these cases, sometimes more than me, just because I have all the orthognathic and pathology in the back of my mind. And when patients come in for post-op, she's very in tune with what we've done, where they're at. And from a hospital standpoint, she's able to help put in notes and orders and stuff for, orthognathic patients going to the hospital. So I think having a APP is a very valuable asset if you're doing a lot of hospital and major surgery stuff. But probably the main reason that we can do a lot of this orthognathic and TMJ surgery in an outpatient setting is when you have an accredited OR, anytime you do a surgery, you get a surgical fee, right? So if you do an arthroplasty in the hospital versus in the office, you're getting your surgical reimbursement. But the difference of having these surgery centers is if you take them to the hospital then collects what's called the facility fee. So what they're billing out for all of the drapes, all of the local, all of the blades, everything like that. But if you're doing that surgery in your own surgery center, that facility fee is then collected by you. And then that makes the surgery a lot more profitable for the surgeon because you're basically owning the surgery center. And again, obviously, I'm not doing this purely for finances because it would be more lucrative to just do wisdom teeth. But by doing that, it kind of negates the stereotype of doing orthognathic surgery and TMJ surgery doesn't pay in private practice, because once you add in the facility fee, it's pretty profitable.
Right. And you just brought up the great point. The difference when you do something in the hospital absorbs the cost. If you keep it in your facility, you and your team gets to do the cost. My question then is, do you know what the hospital's fee is, and then how you can kind of keep it just about the same, maybe a little bit better? You know what I mean? Like, for comparison.
I actually don't know the exact comparison, but we have basically a financial team, and then we have a reimbursement team. Then we have people who every year kind of renegotiate contracts. So we have certain contract negotiations with, pick your private insurance company, and we can come to them and say, hey, we do this volume. This is the amount it costs us to get these plates and screws. This is what our current facility fee is. This is what we think would be reasonable. And then they can look at what their contract with the different hospitals is, and then they can kind of find a middle ground. But we don't tend to know exactly what the hospital is billing for the facility fee, but we have an idea to kind of present that. But the important thing is, a lot of people think of TMJ and orthognathic surgery as a hospital procedure. And I think that the mentality that we have is, well, if we have the same providers, same anesthesia staff, it minimizes fluid, it minimizes OR time. We're doing arthroplasties in 30, 45 minutes, double jaws in 1 to 2 hours. And it just keeps all the swelling down, and it really helps patients kind of get in and out. But at the end of the day, we still want safest for the patient. That's why we all have block time at the hospital still. So, I had a patient who was, he needed a Lafort BSSO recently, and he had a history of some vascular issues. So that's still a hospital case. The thing is that we're trying to maximize all the profit with facility fees and things like that. We still will bring patients to the hospital with orthognathic surgery, still bring patients to do arthroplasties and things like that. But it just allows for a different option that people may have not thought of. And then again, if you're able to do the surgery as an outpatient surgery, it does make it a lot more profitable, which makes this much more feasible long term instead of trying to constantly take a hit on each orthognathic surgery they do. Because I know a lot of people, they tell me that they do a handful of cases a year, but every time they do it, they have to block out 2 surgeons a day. They have to go to the hospital, and then their reimbursement's like $500. And both of them lost the whole day of doing sedations and consults. And then after a few times of doing that, they're like, well, I'm not going to do this anymore. So the whole point of this is making it sustainable. And it's something that they built long before I got here, but it's something that I luckily get to continue. And it looks like the trajectory is, we can do this for a long time here.
Yeah. I'd be so curious to see if we could find out some, like send, what do they have? Like the mystery shoppers or ghost shoppers, or like send a couple patients in, like, hey, go get a consult at the hospital, see what they would do this TMJ surgery for. That would be so interesting to see. Cause I mean, at least in the Northeast, we're finding out more and more that like the fees in the hospital different from the outpatient offices or practices, and the whole point is like the reimbursement's different, and then the big hospital and big multi-groups are buying the smaller places because the profit's there, when you could get the outpatient offices that have a lower cost, and then you could keep the same in-hospital fees, the reimbursement from them seems to be, if you could, and I'm sure they're probably doing it to you guys down there too. I hope that that we could figure out a way in the future to keep it fair between these big corporations and, quote unquote small. You guys are a big group, but smaller outpatient offices. Yeah, that's the heart of patient care right there. Making sure that people can get what they need for a good price, but and
Well, the
also make sure
stereotype
that
is
the smaller guys stay in business. Oh yeah, sure.
the
Sorry.
stereotype is, if you go to the hospital and you open up an extra pack of suture, they're going to charge you $50 for that chromic. And that's kind of the joke that people make every time you open up something in the OR is, oh, it's going to cost a couple $100s. And to your point, private equity is becoming a huge thing in our specialty. That's just kind of the way things are going. Our group, Carolina Center for Oral and Facial Surgery, when I joined, I think we had maybe 10 locations and maybe in the high teens or low 20s doctors. And obviously we're approached by a bunch of different private equity people. Our mindset was, well, if we join one of these big companies, they're going to first say, well, let's not do maxillofacial surgery, right? It's going to take a lot of time. Sometimes you need two surgeons. Reimbursement, you got to file through medical. That can be difficult. So the things that we were concerned was we want to be able to continue this maxillofacial side of things. And basically what we did was we partnered with private equity to create a multi-specialty platform called Flagship Specialty Partners. And what it does is allows for different oral surgery groups, for example, different ones in North Carolina, in Virginia, to join under our umbrella, but everyone still does it their own way. But now we have a group of, like I said, 50, 60 plus surgeons, and it allows for us to get a lot more of the buying power for equipment with insurance companies. Even within Carolina Center for Oral and Facial Surgery, we all do things very differently. Some people do TMJ surgery. Some people, don't do full art surgery. Some people go to the hospital. Some people don't. Some people take off Wednesdays. I do consult day Mondays. Some people have a nurse. Some people don't have a nurse. So we all get to do things individually. So outside of CCFS, the groups in Virginia and things like that, they completely have their own way of doing things. But because we're all under this flagship umbrella, it really helps us grow and negotiate with insurance companies, with implant companies. And I think that luckily we've been able to kind of get the best of both worlds, getting some of that benefit of private equity. But our board members are people like Brian Farrow, other surgeons. So it allows for us to dictate, hey, I know that this doesn't make sense, but this is what we're doing clinically. And people who are joining our group a lot of time ask me if I'm happy, and they try to, tell me what I can or cannot do. And I still do Medicaid orthognathic surgery, which I'm sure everyone knows. If you do a double jaw, it pays a few $100s, and it's not the best use of your time, but no one has ever told me not to. And I think it's a good service, and it's something that I do here. So that shows you that they're not really kind of trying to maximize profit necessarily and take away your clinical scope. At the end of the day, having those insurance contracts to do in-office TMJ surgery, these things all kind of help balance each other out, and being able to buy implants at lower rates because we have such a large amount of providers definitely makes a difference.
Oh, for sure. It sounds like you have a similar model to the Max Surgical under Jason Auerbach kind of thing. It sounds very similar to that, but different. You guys are doing, it sounds like you're doing a lot more OR than his group. But yeah, so you got 50, 60 surgeons in your group now. Wow. Is there a goal? I'm wondering, you guys are just going to keep expanding probably, right?
Yeah, I think we're trying to mostly keep it to the Southeast just because it's easier to kind of manage, as opposed to having people from all over the place. But we have basically a great team of people who centrally act as a support team, and they can help with recruitment for new surgeons who want to join in, or they can help with, say, maybe there is that one solo guy who's doing orthognathic surgery in the Southeast, but wants to be under a bigger umbrella and have access to how do you build a Triple HC accredited OR? How do you get better insurance contracts for orthognathic surgery? So we definitely have a good team that helps people who want to come under the umbrella or to grow. But the nice thing is, from my standpoint, I just kind of get to build my practice and do these types of cases. And they support my side projects. For something like this board course, I went to Brian and some of the other partners and said, hey, I think this would be great to do. We already have a bunch of people, fellows, residents who want to do it. What if we just open it up to residents and graduates across the country? And we have a great team. Dee Dee, she kind of messaged you and helped set up the hotel, help get all the blocks of rooms and things like that. So there's a lot of support for people's, passion projects. And I'm lucky that all the surgeons and the people in the group kind of help me out with things like that, not just growing into the practice, but things like this board course. I think it's great. You'll see when you're there, it's very collegiate. People kind of will help you in whatever it is that you're looking to gain from it. But then at the dinner, everyone is just kind of getting to know each other. And it was really neat. Last year, like I said, it's about 50-50 between residents and graduates. But out of all of the graduates who took the board exam last year, we had 100% pass. So I get to hear messages from people after boards and tell me, that they found it helpful. And then it's just kind of building each year. So it's just really cool to have their support, surgically, but also in kind of other things that we're trying to accomplish as well.
100% pass. That's a huge rate. And you said about 30 proctors. Were these proctors all from your group or other groups too, right?
They were pretty much all from our group except for a few. So there was Michael Maloro, from UIC. There was Steve Press, who runs the Nashville course. So we do have some people who are outside the group who we just know are very knowledgeable, very helpful with this kind of stuff. This year, we're looking to add some other people as well. So I think Yenzer will be joining, and I think overall just be a good experience to get everyone's opinion on things. But I would say the bulk of the proctors are from the group. Yeah.
Excellent. Hey, this is going to be great, man. And thanks for coming on today. Thanks for taking some of your time out of the busy schedule. You give me some times, and I know how tight you are. So thanks a lot, man. Thanks a lot, Dr. Pham.
No, thanks for having me on. I build in the admin time for stuff like this, so it's really cool to be able to interact with people like you who are just trying to make things more accessible to people who are coming through residency, people who are afterwards. So I'm very lucky where, like I said, I kind of came to an area that didn't have someone practicing maxillofacial surgery. I had a very supportive group, mentors who were willing to kind of spend their time teaching me. And I think that's probably the biggest thing, is having good mentors when you come out. But I think that it's a great way to practice, doing maxillofacial surgery in private practice. And a lot of people coming into residency say they want to do that. So if there's any way that I can help, this was just how I did it. But depending on where people move to, there might be different nuances. And I hop on a lot of phone calls with people who are just starting out practice. And if there's anything I can do to help with people getting into it or looking for jobs and have questions about stuff like that, I'm happy to chat and do what I can to help out.
Yeah. And what can I put in the caption? Maybe like an email? Should I put your Instagram? What is there anywhere you find yourself accessible? Like what would be best for you? Because I don't want people to just bombard you if that was to happen,
Yeah, no, I'm happy to give you my cell phone, email, and then my Instagram is just PHAMOMFS. People reach out to me on social media a whole bunch of the times, but you're welcome to put my contact out there. And if people still want to sign up for the boards course, basically we have probably till mid-September. Then we have to cut it off just to make sure that we have the adequate number of proctors. But yeah, if they want to join on the board course, it's open to residents and graduates. And if they have any questions about practice, I'm happy to do that as well. But appreciate your time. I know that you probably have a bunch of different people who are coming through the podcast. So I'm really happy to be able to be a guest on it.
Oh, well, thank you. It's an exciting time. I'm super excited to finally start that chapter of actual being an oral surgeon for once, this route of all these years of education, all these exams. And I really appreciate speaking to you today, because the model that you have, it seems like you're maximizing efficiency, and you're also maximizing your passions within the surgery itself. You're maximizing helping patients in their unique ways and needs. So no, this is really eye-opening. I wish I'd like to, I have a lot of questions. I'll ask you in person though too, because I know we're getting towards that hour point. So, well, yeah. So thanks, Dr. Pham, and I'll talk to you soon. I'll put your contact info, that email, in the caption. I'm going to put the link, and I'm going to put the information to the boards course in the caption as well. And anything else I could do to support you and obviously the course, let me know. All right.
Yeah, man. Good luck. Congrats on getting all your licensure, and have fun finally getting to get paid for taking teeth out.
All right, man. Thank you. I know there was a lag, but this is good. This is great. All right, Dr. Pham. I'll talk to you soon.
All right. Take care.